Grand Rounds 2017. My name is Tom Ford and I'm the chair of Grand Rounds. Thanks very much for coming. You'll remember at the end of last year there was a huge kerfuffle with the IT and we were moved from here to the Wolfson. We have the new fancy IT. It's still got its protective sheet over the front of the screen. Well, it did until I took it off. But it still doesn't work, and Perth are struggling to dial into us. We're going to find out how many people are in Perth, and if there's loads, the slides might disappear for a short while, and these guys will have to just freestyle for a bit whilst they appear. So if there is a bit of screens disappearing, that's us trying to work in the background. I hope you all had a good festive break, Happy New Year, etc. I'm not entirely sure how long you have to go before you stop saying that, but that's me done it to all you lot now. So a few parish notices. I've got quite a lot. They've been built up. I shall go quickly, and we'll get on to the main event, the DNA CPR policy from the Correctly Spelt, Barry Classen, Michael Clark and Ali Ramsey. A study completed at the University of Dundee has shown for the first time a simple test can predict chest infections before they occur in patients with bronchiectasis, a common but important lung condition which affects patients of all ages. This study was led by the School of Medicine's Dr. James Chalmers, there he is, and he measured an enzyme in the lungs that's released when the infection is building up, called neutrophil elastase, and it shows that patients who have a surge in their neutrophil elastase are likely to get chest infections. This was published in the American Journal of Respiratory and Critical Care Medicine. I was involved in this, but it doesn't seem to be mentioned anywhere on the press release. Not that I'm bitter. School of Medicine student Ian Heineman has been hard at work establishing the British Oncology Network for Undergraduate Societies, or BONUS, bringing together societies from universities all over the country to help promote oncology as a speciality, to facilitate networking between students with an interest in oncology, allowing them to share resources. The network is run entirely by students, for students, with more than 30 involved from the schools of medicine at 18 institutions. And BONUS will hold its inaugural conference this year, so congratulations to Ian, who sorted that out. A molecular volume control may one day be used to manipulate enzyme activity in order to control the development and treatment of cancer, according to the research carried out here in Dundee and also in Bath. The researchers have uncovered new functions of an enzyme called dual specificity phosphatase 5, DUSP5, which will help scientists to better understand how tumours overlap. This was published in the Proceedings of the National Academy of Sciences, which sounds very important. This year's Discovery Days, confusingly, only last one day. This is out of order. We're missing a slide, I'm sorry. Discovery Days, there we go. The day is tomorrow. Head down to the Dalhousie building on main campus to hear some of the university's newest professors discussing their research. There's plenty of interest, including Professor Sarah Brown discussing work on eczema, Professor Ghulam Nabi and his work on detecting and treating bladder cancer, and kidney and prostate cancer. If you've got the opportunity to go down tomorrow morning, or in fact indeed all day, try and make it across there. And the Saturday evening lecture series starts up again this month, kicking off with a talk from the University of Dundee graduate and Chief Executive of Archie, David Cunningham. David will be covering the untold story of the Old Woolly Bucket Trail, which is not to be missed. Early stage trainees can apply for a travel award of up to £300 to present at national and international scientific meetings. Applications close on the 1st of February, so if you're planning to present somewhere this year, don't leave it too late. And finally, if you fancied working somewhere more rural than Dundee, then the Integrated Longitudinal Clerkship could be for you. Students undertake a 10-month long placement based in either Dumfries and Galloway or the Highlands, and there's information on the slide here, but if you are a student and want to get involved in this, please email Penny Lockwood. So, without much further ado, I was asked last semester if the CPR team could have... Which one's first? That one. Have a slot to talk about DNA CPR in light of the change which has happened nationally. Unfortunately, we were completely full, and this is the first opportunity that we've had to welcome them to Grand Rounds, and they've brought a whole team of folk, and we're starting off with Barry? Yeah. Excellent. And I'll leave it to them to organise themselves. There will be questions and answers at the end, so I'll be around with my roving microphone. Thanks so much, Barry.
Thank you, Tom. A warm Happy New Year from your friends in the emergency department, and most specifically from your friends who form the multidisciplinary team that is Tayside CPR Committee. It was perhaps a slight problem we couldn't get into Grand Rounds at the end of last year, because Scottish Government outlined in 2016 the new plans for a DNA CPR policy, but they're not really being implemented until the first quarter of this year, 2017. So being the first presentation in the new term of Grand Rounds is a very opportune moment for us to do that. I'm Barry Clarkson. As I said, I work in emergency medicine down in the bowels of the hospital at level 4, and I also, for the last number of years, have chaired Tayside CPR Committee. What we intend to do for you today is just everyone's aware of DNA CPR policy, but is everybody implementing it optimally as we can? Our new Chief Medical Officer, Catherine Calderwood, in her report last year, outlined a plea for a look at realistic medicine. Nothing could be more important in realistic medicine than the futility of doing CPR on patients of whom it won't benefit them and just cause undue distress and trauma for them. So, without much further ado, I'm going to hand over to one of our hard-working resuscitation officers, Mike Clark, who's going to outline a summary of the changes in the new policy, and then Ali Ramsey, who's an FY2 in general practice, with a little bit of an inkling of a lean towards a palliative care career, I'm getting the suspicion of. He's going to give us a flavour of an audit she's undertaken to show how we've performed in Tayside over last year in over a month, a snapshot audit of last month of how we worked putting out DNA CPR policies and how we implemented and how complete they were. So I think you might find that quite interesting. If there are any burning questions at the end of each presentation, the guys will take those, but it might be better to leave it to the end and have a lights up and a general question and answers at the end. One of the things that we really need, it's not the FY2 on the ward's duty to fill out the DNA CPR for a patient. It's not the registrar's duty. It's not the senior nurse's duty. It's not the consultant's duty. It's actually everybody's duty. And it isn't a request. It is actually a Scottish Government standard that we should be doing this. You're going to get some of the figures coming out of the two presentations that will maybe feed a little bit of a dialogue, and we're happy to take questions at the end. So without further ado, I'd like to hand over to Mike Clark, one of the resuscitation officers from Tayside, who's going to outline the new policy. Thanks, Mike.
Hi, good afternoon, folks. I take it I'm standing close enough to the mic. Everybody okay for hearing? Grand, I'll try not to talk too loudly. So, as Mr Clarkson said, my name's Mike Clark. I'm one of the resuscitation officers in NHS Tayside, primarily based in PRI, but based throughout the different hospitals in the organisation. And my background's accident and emergency, so I did a sort of prolonged stint, 15 years there. So some of you may recognise me from there. But on behalf of Tayside CPR Committee, we've been asked to present some of the regards to the update in the existing policy. So most of you will be aware that this policy has been in place for a period of time, and so I'm not going to go through every minutiae of the policy, but I'll try and focus on the changes in the policy. So as I say, I'll look at a little bit about the policy, then I'll talk about the background to the changes and the specific changes, and focusing a lot on the communication aspect, which we need to try and improve on throughout the organisation, and it's throughout Scotland, as Mr Clarkson has said. So key points of the policy. DNA CPR decision, it's intended to prevent these inappropriate CPR attempts, resuscitation attempts, when it clearly would not work for the patient nor be wanted by the patient. And I must say that's probably the majority of calls that we get called to. Retrospectively, when we look at it, we probably think a lot of the patients could fit into these categories. Also, significantly, CPR should never be offered as a treatment option when it's clear that it would not achieve sustainable and spontaneous breathing and circulation. So that's quite significant, that the patient should be able to sustain that independently. Likewise significant, we should not just default to doing nothing with regards to DNA CPR and allowing CPR to take place as a matter of default, because that's unacceptable clinical practice, and we should not just be saying, well, we'll do it, and knowing what the likely outcome is going to be. Within survival to discharge in general from in-hospital patients sits at about 15 to 20% of patients who have a cardiac arrest in hospital survive to discharge. So that's looking at all bodies of patients. So it's not looking at those that are have got significant comorbidities or terminal illnesses. That's looking at everyone across the board. So less than 1 in 5 patients survive to discharge. So we don't get an awful lot of these patients to a stage where they can go home. So we should be thinking much more so. If 4 out of 5 of them die, should we be doing CPR on as many? Probably not. So the original policy came into place in 2010, and that was an integrated policy between primary, secondary care as well. And it was fully integrated, I say, between primary and secondary, supported by Scottish Ambulance Service, Police Scotland and the Crown Prosecution Service, because lots of the out-of-hospital cardiac arrests subsequently involve Police Scotland and the Crown Prosecution Service, because it's a sudden death, which is hugely traumatic to families involved in these situations. So it probably involves us in hospital a bit less so, but maybe I'll have a few people in the audience that are from primary care as well. There was a light touch review in 2015, which was sort of the changes were made in 2016, and we are implementing in Tayside from the 1st of February 2017, and that follows guidance from the BMA and a couple of legal cases, and one significant legal case that I'll touch on shortly. So just a brief review of the existing policy. There's a decision-making framework on the front of the pads that you have, which will assist medical and nursing staff, as Barry has said. It's not one person's decision, but primarily the recording is generally of the senior clinician with responsibility for that patient. So in hospital, it's typically consultant. Out of hospital, it's typically GP. But there may be some caveats to that where senior nurses in care homes, etc., will have that responsibility. And it's a complex decision. I don't want to stand up here and seem all pious as if it's very easy to make that decision. It's not. I'm aware of that. There's lots of emotions involved, and it's never black and white. So I appreciate there are difficulties involved in that. When the form itself is completed, it's a single high visibility form, which most of you in the room may well be familiar with. And that form should stay with the patient and should transfer with them between different hospitals, between primary, secondary care settings, and should be applicable for transit purposes as well with the ambulance service. Along with that, we should always be providing information booklets so that the patients have got sufficient information and their relatives have sufficient information. The policy itself is quite easy reading, and it's a very thorough policy, and the patient information leaflet summarises that. And I've got sort of packs made up if anybody needs them, which will give information for generally ward staff who are ordering the new DNA CPR pads and information leaflets. So I've got that at the end if anybody's needing that. So why do we need it? Why does it need to be integrated? Unfortunately, we're still getting lots of inappropriate resuscitation attempts. Lawson, my colleague, did a review of the pink forms, which are the pink resuscitation record forms that get completed post any 2222 event, whether it be a medical emergency or a cardiac arrest. He looked at that, and just very subjectively looking at the information of the patient's medical history, preceding events within Tayside in the last year, he's looked at probably 25% of the patients who had CPR carried out on them should have, given the history beforehand, had a DNA CPR written. And again, it's subjective, but it's very clear. I've got a couple of examples here, and I'm in the darkness here, and 49-and-a-half-year-old eyes aren't great at reading in the darkness, but just a couple of them. We've got a 92-year-old admitted following a fall, has had an anterior chest wall pain, Parkinson's, vascular dementia, CVA and hypertension. There was a call put out for the patient, and a DNA CPR decision was made by the team who probably do not know that patient particularly well. So that decision should be made by the clinicians that are looking after the patient. Another one, a patient COPD, CVA, ischemic heart disease, was in a care home, poor comorbid state, and they had a PEA arrest within the hospital. They had CPR carried out on them, and they had a return of spontaneous circulation. They got a DNA CPR form completed immediately, and they died 25 minutes later. So, and these are just a couple of examples. We've got tons of them, and these are happening within NHS Tayside. And again, we don't want to sit in judgment because it is difficult to make these decisions at times. But if we can try and make these decisions beforehand, so it's not the 2 o'clock in the morning call for an FY or an ST to make that decision if a patient he or she does not know, when there's a consultant-led ward round that may have been able to make that decision in the cold light of day and make the communication process better as well. Unfortunately, I've disappeared from the screen. But what the other things that the important aspects are that sometimes, and we keep hearing in our training, that CPR is being offered as a treatment choice to patients who are getting towards the end of their natural end of life, so within the last year of life likely, that is being offered as a treatment option. Do you want to be resuscitated? And that shouldn't be the choice when it's clear that the patient would not be successful. Okay, and again, that's a difficult line to draw when it would clearly not be successful. And also, we're still hearing anecdotally, and it's still happening, that medical staff are asking relatives if they want, or to ask the relatives to make the DNE CPR decision. Okay, in the vast majority of cases, when it is clear the patient will not survive a cardiac arrest, that decision is made by the clinical team and is then communicated effectively and appropriately to the patient, and if required, the relative as well. Okay, so it's not a patient decision that makes it, and if it's not going to be successful, it's a clinical decision. And I'm getting I've got floaty clouds and a really interesting talk. I'm sure you'll all be drawn towards the floaty clouds. So, there is a lot of movement of staff between different wards. There is a lot of movement between patients between different wards. So the DNE CPR there is there as a communication tool to help with these shifting of staff and shifting of patients. And I say it's transferable to community settings as well as between hospital settings. There was a study done a couple of years back, 3 years ago now, within Scottish hospitals, and it looked at 25 acute Scottish hospitals, and it looked at about 31,000 patients within the wards within these hospitals. And a review was done a year later. 30% of these patients had subsequently died within that year period. And in the time that the patients were in the hospital in that first admission, 10% of the patients died in that first admission. So a third of patients that are in the hospital beds right now will be dead within a year's time. And NHS Lothian did a review as well, and they did a 48-hour review of all in-hospital patients. And within a year, 30% of these patients were dead as well. So unfortunately, we do look after a much more complex background of patients who will not, a lot of them will not survive, a third of them will not survive within a year. So changes to the report. There was a couple of Scottish Government Health and Strategic Framework for Palliative Care documents came through. Probably more significantly for the DNE CPR was the Tracy versus Cambridge University judgment, and that came on the back of a patient who was undergoing palliative care, who had specifically requested to be involved in all aspects of her care. It was a reasonably young patient. She'd requested to be involved in all aspects of her care. A DNE CPR form was completed, which subsequently was deemed to be the correct plan to have a DNE CPR, but there was no communication with the patient, and then the family found out retrospectively that they had a DNE CPR form completed. So that caused huge upset, huge angst, and then lots of legal wrangling going on. So now the law is that we default to speaking to patients unless it's going to cause physical or psychological harm. So the responsibility is with the clinicians making the decisions to communicate with these patients as early as possible. Okay, and that all works in with the joint document that came from BMA, RCN, Resus Council UK, and it's with the decisions relating to CPR decisions, and that was revised last year as well. If any of you have been on any of the courses that the resuscitation team within Tayside run, you'll hear us banging on about the chain of survival. We now bang on about the chain of prevention, which is much more important because we need to prevent the cardiac arrest, because most patients do not survive them. So although the chain of survival is important, I'm not want to talk myself out of a job, the chain of prevention is very important. But before that chain, before that link, comes a really important link of communication. So good communication, conversation with adequate information, or high quality rather than adequate information, with explanation and advanced care planning. Okay, so that should come in, and that's what most of you guys are involved in. I get called, or we get called as resource team members to get involved in the chain of survival. This comes into every patient care, but good communication. So with carrying on the focus on communication, DNA CPR should not be seen as the focus, but as that prompt to initiate good communication, to try and find out between the medical teams and the nursing teams as to what should be the ceiling of care for these patients. And within advanced care planning, anticipated care planning, you might decide this patient remains at ward level care. They're not for HDU, they're not for ITU. So that decision can be made. And often when these decisions are getting made, DNA CPR should come into that being as well. Some of you may be aware of this deteriorating patient structured response document that came out in August of last year in Tayside. And that's a really good focus when somebody has a high national early warning score and triggers a call to hospital at night, hospital at weekend, or an FYST, then this form should be completed, and it focuses in on that acute deterioration episode, and part of that form now highlights, is there a DNA CPR order in place? Should we be discussing that? So it's getting raised at an early stage to prevent that 3 o'clock in the morning, what are we going to do? Okay. So this is the new form. This is the front of the pad, and it looks pretty similar, and there's a couple of subtle changes within the document itself, but this should be available in all your clinical areas, so it should be readily available, and it does help in communication, and I know it's a complex decision, and there are the flow charts that you can follow down, and it does give more guidance on the back of that. There's much more guidance to aid you in that decision making when it comes to the complexities of patients that do not have capacity, but have somebody appointed to be the representative, or a patient that doesn't have capacity who does not have somebody appointed. So it does give you much more guidance. I'm not going to go through all of that right now, because it's on the document and it's there. But if there's any questions at the end, we can ask that. But it is a quick reference, and there's more information in the policy. But there's policies everywhere, and being honest, we probably don't all read them. But if you're going to be involved in this decision, the decision making, it would be beneficial if you can read it. Okay, so that's what's on the front of the pad, so you should be able to access that. So specifically new on the DNA CPR, going back to the communication aspect, is that patients must be made aware of a DNA CPR decision when it will not work. Okay, that's the law now, that we need to make patients aware of that, and that's come from that legal case. So we need to be all attempts. So if we cannot have that conversation, if the conversation cannot take place, then we still do the DNA CPR form. That doesn't change our decision making and the purpose behind and the process behind the decision making. It's still in place, and we should be documenting the plan to review at an early opportunity to take that conversation, and also document in their medical notes why that conversation didn't take place. Okay, the Tracy versus Cambridge, the law team afterwards said that it was reasonable not to have that conversation if it was at high risk of causing psychological or physical harm, not distress, because it was in the legal case that said that they didn't want to discuss it with the patient because they thought it would cause distress. Legally, they felt as clinicians we should be able to support and manage patients who are distressed, because it will be an upsetting time, it will be difficult for them. But if we feel it's going to cause physical or psychological harm, and they have not specifically said what that harm would be, but if you felt that would be harmful to that patient coming towards the end of their life, then you need to document down that that's why you have not discussed it and why you think it's going to cause that harm. Okay, so distress and upset is something that we have to try and manage. Okay. And also, if the patient doesn't have the capacity and reasonable efforts have been made to contact their guardian or those close to the patient have failed. Okay, so we can still write the form, but we need to document that down as well. So here's another situation. Those close to the patient who lack capacity must be made of a DNA CPR decision without delay when it won't work. Okay, so as best as possible, we should be contacting the patients who lack capacity. Again, if we can't have that conversation, we still make that clinical decision. The clinical decision is still appropriate and in place, But we need to make, again, clear documentation as to why we've not contacted the patient's relative or their guardian. Now, their guardian can be involved. If you think the patient might have a reasonable chance of making successful recovery following a cardiac arrest, all communication has to be made with the patient. You don't make that decision then. But so if you feel as a clinician that the patient may survive that cardiac arrest with a good outcome, then you need to make the discussion with the patient and with the legal guardian if appropriate. So it's only if you feel it is not going to be successful that you make the decision as clinicians. So that's the vast majority of times that you will be making that decision. Okay, I sound without delay, but we've got to be realistic. If it's 3 o'clock in the morning, we don't want to be having that conversation on the telephone. If you're contacting a relative to say that their mum or their dad, whoever, has deteriorated, then we can make that face-to-face conversation, but we still make the DNA CPR decision. But we document to have the conversation, to have the communication with the relative on their arrival face-to-face. That's got to be the best communication process. Okay, so also new to the policy, where we are certain that DNA CPR decision will be appropriate until the patient's end of life, we do not need to review it. Previously, we had to say a time frame, so until the 30th of March or whatever it may be, we would write that in. But now we can leave it, we can tick the box that said the review is not needed as the decision will remain applicable till the end of life. Okay, so that's, and I think Ali will probably talk about that. That's an area that wasn't successfully completed within most DNACPR or within a lot of DNACPR forums. So now we can complete until end of life. If there's any change, if the patient goes from primary care to a secondary care setting, the person taking over their care should review that it's still appropriate and sign that they agree that they review that it's still appropriate. Okay. So the form itself, it looks pretty similar. It's still that high visibility form with the band down the side saying DNA CPR, biographical details at the top as normal, and there's the 2 different boxes. Box A, which, and I've got a dreadful presentation of it here, and it's not come out hugely clear so apologies for that. But box A is the one that you will be completing most of the time. It's when you feel that it will not be successful, you document the reason why it will not be successful, and you have to document about the communication with relatives as well. Further information should always be written in the patient's notes, okay, because this is a communication tool, it's not a legal document, and we hear things saying, oh, we had to do CPR because it wasn't signed and it was a week out of date, and so it's not legal anymore. But it's not a legal document, it's a communication tool. What is legal is the further information that you put in their medical notes as the rationale behind and the communication that you've had. So it's just to be aware it's purely a communication tool which should be transferable between different areas. If the patient has an existing DNA CPR form, it's still valid. Okay, if we're reviewing the existing one because they still have the existing ones still have the dates on them, we change them to a new one. And I've got information for ward environments or ward areas that need to order DNA CPR pads and patient information leaflets, so I've got that for you if you need that. It's applicable to ambulance services, as I say, so it's a communication tool to ambulance service, and that's an area where we often sort of forget the difficulties that can be associated. That's when a patient's pretty vulnerable. If they're being transferred home for end-of-life care from either an acute hospital or even palliative setting, and they're in a hospital and they're in an ambulance, the ambulance service have to have clear communication as to what's going to happen with that patient during that transfer. And those of you that work in primary care will be aware of the KISS system that should be updated, the key information system that should be updated and accessible to primary care staff, out-of-hour staff and GPs. So it should be an e-version to say that we have the DNA CPR form has been completed as well. I touched on the patient information booklets, and these should always be given. So when a discussion is being made, we should always be given the patient information booklet. Now, this discussion might take place over a case of two consultations. You might be meeting your patient at one stage to talk about the goals in their care and might not feel it's appropriate to discuss DNA CPR at that stage. So go back to the patient the next day when they've had some appreciation of what you've agreed with them then, and maybe bring this into being as towards the end of life care. So it doesn't all have to be bang, bang, bang. You're responsible for the care of your patients. You'll know your patients and how best to communicate with them. Okay, but just try your best to get that communication going as early as possible with regards to DNA CPR. And just as a recap, DNA CPR does not mean we do not do other treatments. And again, I think patients and families feel that it's like a withdrawal of care. Is it euthanasia? No, not at all. It's purely in the event if you stop in breathing, your heart stopping, we will not press on your chest, we will not artificially ventilate you, but we will do all other care for you in that interim period. And it also means that it does not mean that you should not put a 2222 call out for that patient. If a patient is needing some intervention of care, airway management for example, then we can still put a 2222 call out and appropriate care is given by that team. But we do not do CPR, which is realistically is probably not going to work, and it's pretty brutal. They're going to end up with some underlying likely hypoxic brain injury, chest trauma. It's pretty unpleasant for all the team involved, let's be honest. So we should be getting it all as best practice for the patient and the patients staff looking after them. I've said any questions, but I'll probably best leaving it to the end if Tom's got the roving mic, because we're going to go into the next presentation, unless there's anything burning. Good, nothing burning. So, just to summarise, the DNA CPR decision is intended to prevent inappropriate attempts at CPR. There should always be a presumption in favour of informing the patients of a DNA CPR decision, and if the patient is in agreement to that, their relatives as well. Document evidence of communication is essential, as is document evidence if we have not had that communication. That's essential. The DNA CPR form is not a legal document, it's a communication tool. And by failing to make that decision, it can result in undignified death, unnecessary stress for patients and families, especially at home, and potential conflict between teams who do not know that patient when they arrive, and that's unfair for everyone involved. Okay, thanks for your time, folks. I'll pass back to Barry, who will then introduce the next speaker. Thank you.
You got it. Can you just pop it up?
Yeah, I will.
Ali, do you want to step forward, because we won't have a great long introduction. Ali Ramsey is an FY2 in general practice, as I said. She did a piece of work last year looking and auditing the completion of DNA CPRs over a snapshot month in Tayside. And hopefully her presentation and her data will inform some of the question and answer discussions that we'll have at the end, that will also pick up any points you might have for Mike or myself. Thanks, Ali.
Thank you, Mr. Claassen. Thank you, Mike. Like you said, my name's Ali and I'm a current FY2 in general practice, and I did a review of the old DNA CPR forms here in Tayside. So overall, my objective was to review the NHS Tayside's compliance with the recommendations from the Resus Council regarding the DNA CPR orders, and I looked across three main objectives. So first was to see how accurately we were completing the DNA CPR forms, also how well we were documenting the decision and the discussions with patients and their relatives about this decision, as well as looking at staff attitudes towards the appropriateness of implementing the forms. So you're all probably quite familiar. This is the old form that we, up until probably early next month, are going to continue using. So what I was looking at was how well we're filling in the front section of the form here in Tayside. Just to give you a bit of background, there have been two recent audits done by a couple other trusts. Nearly identical audit done in Northern Ireland a couple of years ago found that some sections of the DNA CPR form had not been filled in, with particular respects to documenting who they'd had the discussion with on the form. And another audit in Birmingham found that nearly a third of all DNA CPR forms had not actually been filled in completely. So the next bit of my audit was looking at the documentation of the decision. This comes straight from the new guidance from the Resus Council, where it says that clear and full documentation of decisions is an essential part of high quality care. And it does require us to not just only document on the form itself, but also in the notes, because as Mike was saying, it's the notes that are the legally binding bit. But also, more importantly, stressing the fact that if we can't have the discussion at that time about the DNA CPR decision for whatever reason, you have to fully document this and explain why, as well as any plans for future discussion. So again, looking at the other audits, Birmingham found that 12% of relatives and 15% of patients actually didn't know that they had a DNA CPR decision in place, so there had been no discussion with them. And the study in Northern Ireland found that, again, nearly a third of the decisions had no documentation of a discussion with patients or their relatives. So the way I did this was the Resource Council had 3 pre-made questionnaires that I used in order to assess the objectives that I talked about earlier. I only included DNA CPR forms that had been filled in this current admission, so I didn't include forms that had been done in the community and the patients had brought in with them. I only went to each ward once to both speak to staff as well as to assess the forms. I wouldn't go back again later. And I collected all of my data in October of last year. So to assess how well we're filling in the form, I looked at 5 key points on the form, on the pre-made questionnaire that I used. So the first of which was looking at the demographic information, but also looking at why the DNA CPR decision had been made. So if one of these 3 reasons was ticked. Looking to see if the form had been signed and dated by a doctor or a responsible clinician. Then if the form had been signed by a consultant within 72 hours per NHS Tayside policy. And lastly, this tiny little box right at the bottom of the form, which is about the review time period, as Mike was talking about earlier, which is different on the new forms now. As far as looking at the documentation was concerned, I looked to assess these 4 criteria here. So was there documentation either on the form or in the notes? Was there a date, a signature of the doctor in the discussion, as well as a list of who they'd had the discussion with? I also looked in to see if there had been clarification of understanding with the patient and their relatives regarding the DNA CPR decision. And also furthermore, if it didn't look like the decision was discussed, was it documented and were there plans made for future discussion? And lastly, to assess the staff attitudes to our appropriate use, I approached various members of staff, so nurses, doctors, auxiliaries, etc., and asked them this following question. Would you have concerns about attempting to resuscitate any patients at risk of cardiac arrest but who currently have no DNA CPR decision in place? I only wanted a yes or no answer. I didn't want any patient details and I didn't go looking into what their opinions were. So the results, probably the bit that you're all interested in. So overall, I found 80 DNA CPR forms across 29 wards here in Ninewells, but I had to take out 17 of them because they didn't fulfil my inclusion criteria. So that left 63 forms for analysis, 52 were from medical wards, and 11 were from surgical wards. I also spoke to 91 members of staff to ask them about their opinions on the DNA CPR use. Right, so only 27% of the forms I found were actually completed in full. So of those 5 sections, just over a quarter had all 5 sections completed. The good news is the bit that we're doing 100% of the time is that we are stating a reason why the DNA CPR decision's been made, as well as it is being signed and dated by a junior doctor or another relevant person. But as far as demographics go, a quarter of forms don't actually have the full patient details on them. I did require you to have the full name, CAI and address of the patient. So it's not enough to just write a name and a CAI number on the form. You have to put the full details. Surgical wards were, though, statistically more likely to do this than medical wards, with a p-value of less than 0.04. After accounting for forms that were still within the 72-hour time frame per NHS Tayside policy, it still found that over 15% of forms hadn't been signed by a consultant within 72 hours. 3 forms were just signed late, spanning from 4 days to 3 weeks, and 6 forms hadn't been signed at all by a consultant. And perhaps the worst of all was that of those forms that did have a consultant signature on them, only half of them actually had a time review put in place. As far as discussion goes, 65% of the DNA CPR decisions did have documented discussion, both in a combination of the form, the notes, and both. However, you'll note at the bottom that 22 forms had no documentation of a discussion. 6 sets of notes did say that there wasn't a discussion done. However, it's worth noting that they didn't actually specify why, just that it hadn't been discussed. And only 3 of those made plans for future discussion. As far as clarification goes, though, only less than half of the DNA CPR decisions where there was documentation had clarified whether or not the patient or their relatives understood why the decision had been made. So we're not very well documenting this. And as far as staff attitudes go, across the vast majority, you can see 81% of staff did feel that we are using the forms appropriately and that they don't have any concerns about patients in their departments. There are slight differences between doctors and nurses and other members of staff, as well as between medical and surgical wards, but none of this was statistically significant. So overall, we do need to improve our filling in of the DNA CPR forms. Across, even though individually it looks like each of the sections is being filled in adequately enough, like I said before, only just over a quarter actually are being fully completed. So we really need to step up, making sure that we're doing it properly. The main area to address is the valid time review. So, like I said before, it is just a tiny little box at the very bottom of the current DNA CPR form. So it does beg the question, is it just being missed because it's a small bit and it's the last thing you see? Or is it more just we don't fully know how long we want the decision to be valid for? Because most of the time that bit of the form is just left blank. Hopefully, though, with the implementation of the new forms, with that making it a little bit more clear what we mean by a review time frame, it should prompt better decisions regarding this. Because once again, this is from the Resus Council guidance. Decisions about CPR do need to be reviewed at appropriate intervals, especially when there's changes in the patient condition, and it is the responsibility of the healthcare providers to make these decisions regarding CPR or not to CPR. So it is over a third of the DNA CPR forms didn't have any documentation regarding discussions with the patient or relatives if appropriate. Now, it really does beg the question, are we just not documenting, in which case we just need to get better at it, or is it that we're actually not having the discussions? And in which case, if we're not having the discussions, we need to state why we're not having the discussions, because it's no longer acceptable, as Mike was saying, to not discuss with patients or their relatives when appropriate. Of the 6 sets of notes that said that there was no discussion, like I said, there was no statement as to why it wasn't discussed, just that it hadn't been. And only 3 of those actually had stated that they planned to discuss in the future once they could contact someone. But funnily enough, actually, when you go through the notes further beyond that, there still is no documentation as to whether or not it was discussed at all. And like I said before, less than half the notes have any evidence of clarification. Now, again, this begs the question, is it not being documented, or are we actually not clarifying? So hopefully with the new information packs that are coming out with the forms, we can try to improve clarification with patients and make it clear in our documentation that we are explaining the situation to them. For the staff attitudes of appropriate use, they do feel majority of the time that we are using them appropriately, but it is worth noting that 25% of all doctors and nurses across the wards I went to did think that they had patients who required a DNA CPR form. So it does raise the question of, do we just need better communication between the different members of staff to really broaden the area of us talking about DNA CPR for our patients? So obviously no study is perfect, and mine's no exception. So part of the limitations were I collected all of this data out of hours, so once I was done finishing my shift for the day, I then would go around the wards. As a result, that does mean that there's a more limited number of staff to question about the appropriate use of DNA CPR, so it might not be fully indicative of our how appropriately we're using them. I also only looked at 9 wells, so I didn't go to Perth or Strathrow or look at community forums, so it's not entirely indicative of the entirety of NHS Tayside practice. And as I said earlier, I only went to 29 wards. 9 wells obviously has more than 29 wards, so I did include every ward in my audit. So again, it's not indicative of entirety of NHS Tayside practice. But overall, my recommendations are that we just need better documentation across the board, with both documenting on the DNA CPR form and documenting the discussions and clarifying the decision, because ultimately, if it's not documented, it didn't happen, and we really need to be doing that. We also need better liaising between staff members just regarding how appropriately we feel we're using DNA CPR forms. One of the wards I went to, Ward 6, told me that one of the things they do during their morning safety briefs is they actually do discuss, do they have concerns regarding DNA CPR decisions, and if they feel there's any patients that need them that don't have them. And it's discussed right then and there at the safety brief. This is something that could easily be adapted to all the wards for their safety briefs, so that way there is this better communication between staff members, and you don't have staff members who are thinking along the lines of, ooh, I really think this person needs a DNA CPR form, but no one's saying anything, so I'll just keep quiet. So just to try to better that communication amongst ourselves. But with the new forms coming out in the beginning of February of this year, I'm planning to re-audit the new forms to see if we see an improvement in the completion, the documentation of discussion, as well as if there's better communication amongst staff. And that'll hopefully be happening sometime this spring. And we'll see if there's an improvement. I'd like to just thank a few people. So I wanted to thank Ian McDougall, who was the one who prompted me for this project. But he's actually retired now and is probably loving life right now. But thanks to him, as well as to the rest of the resuscitation officers and Mike and the rest of his team, and Mr. Klassen for introducing me today. And those are my references. Yeah.
I think you might as well stay up, Ali, and we'll get Mike up as well. Thank you very much for that. I think there are take-home messages for all of us, and we'll now open the floor to Tom and his roving mic, and we'll grab a few questions from everyone.
I'll start at the front and work backwards.
Hi, I'm one of the paediatricians. My question is, what age do we start using these forms? Because we're moving to taking 16 to 18-year-olds. So should our over 16s use the adult form, whereas our children use a completely different form?
Yeah. This is the adult integrated policy, and the guidance is 16 years and older. Yeah, your ward assistant can order these forms. I'll give you the order form. But yeah, there might still be some over 16s who are still under the care of the child health, who their existing their policy that you've got may well still be applicable, but in general, 16 year over 16 is for the adult policy. Yes.
I think there's a bit of a problem with people who are rapidly evolving clinical situations, and acute heart failure is a very good example where a person can look at death's door, and an hour later or a day later they're sitting up in bed very happy. And it certainly used to be the case that Ward 15 filled in these forms too early on these patients. And these patients used to come up to Ward 1 and be sitting up perfectly happily in bed a day later with somebody having said they should not be resuscitated for those 12 hours. And with the best will in the world, nobody's going to do a DNA CPR form every hour through the night. So I think the rapidly evolving clinical situation, or maybe heart failure is the only one, needs to be given some other thought. And can I ask another question? What is the difference between distress and psychological harm? I mean, that's ridiculous.
If someone can tell me what it is, I'd be more than happy to stand up here, because I appreciate that, and there's been no information come from the result of that sort of legal case as to if what you feel it would cause either distress or physical or psychological harm. Perhaps if you felt somebody may well, if you inform them, they would then stop eating, they stop taking the rest of their medication, then that would cause physical harm to that patient. So if you felt that was the situation, then that's just an example. And I'll let Mr. Klassen answer the other question. No, so that's the situation. You can choose not to discuss that and clearly document that you felt that it would cause in that sort of 72-hour period prior to death, that you felt it would be inappropriate because it would be psychologically harmful to that patient at that stage.
I mean, I think we should take Alan's point about the acute deteriorating patient, because that is a slightly different situation. If you've got someone in acute left ventricular failure that is being actively treated, actively being given, all the treatments that we can offer them, then you're going with that, and it isn't appropriate to do that. But what I think this is trying to address is the increased burden on healthcare of an increasingly elderly population, increasing frailty, complex comorbidity, people who have multiple organ failure. We've all seen them. We all see them on every take, in every area coming through, where it would not be in that patient's best interest to have someone, in the event of a cardiorespiratory arrest, to have someone jump up and down on their chest and do heroics for 30 minutes that would be futile, that might get ROSC for 20 minutes and then stop again. And you know, one of the things I've taken from listening to the two presentations, again, I've read them a little while ago, but take home is what we do in the emergency department. We see, and I think I'm the only one from the emergency department here, but we see patients come into us with DNA CPRs in place. And what we don't do, the new form does, we should actually, in good practice, be documenting that the DNA CPR is in place and it's appropriate to continue with that. But that doesn't mean not to treat them, you know, but we have to make an anticipatory care plan for the patient, a decision on where our ceiling of treatment's going to be for that patient, if it's oral antibiotics or IV antibiotics, but not any further supportive care in HDU or ITU that wouldn't be appropriate. So, totally take your point, Alan. I think, and it's well made. You know, acute patients who come in, we give them the best shot, and it won't be appropriate to save that. But if that doesn't work, you know, if your LVF patient who's had furosemide, had a GTN infusion, has had, you know, CPAP or whatever going on, are you going to then intubate them and do that? No, that's not going to. So that's the ceiling of care. And at that point, it will be appropriate for the team to then say, I think we reach this. They either get better with what we're throwing at them, these three elements of treatment, but we're not going to the next one because it will be futile for them to carry on with that. And that is the hard clinical decision. As to the distress and things, you know, these things, this is now a standard and it's being applied to everybody across Scotland on the Scottish, National Scottish DNA CPR policy. So we are the voices of it being your CPR committee, but we didn't write it. You know, this is written by committee and you will get some of those difficulties. But I think the essence of what they're trying to say is we need to have an open, honest and transparent conversation with our patients and with their relatives if the patient can't have that conversation about where they're seeing it, and not make them feel they're making the decision. It's not what would you want? Would you like CPR? It's not about that. We're saying that CPR wouldn't be of any advantage to you in the event of a deterioration. We're still admitting you, we're still caring for you, we're still treating you, but in the event of a cardiorespiratory arrest, it would not be advantageous to you to come out. And that is a difficult decision, and that's why senior clinicians have to engage with it, and have to be involved in it, and have to buy into it, and have to do it. We instigate DNA CPRs on some patients, and some patients don't even hit the medical floor because they're obviously very near to the end of life. We get some really bad cases come out of nursing homes that come into us on death's door, and they go into the emergency department observation ward in room 1 for a bit of dignity, end of life care, and allow a natural death. And we instigate DNA CPR policies on such patients and discuss it if they're moribund with their relatives who are more than... And you know what? I mean, we don't get much praise in the emergency department, and we're not here for praise, but that one aspect of care that we deliver gives us more compliments to the department than anything else. So, you know, I think that's what it's about. It's trying to get more engagement with everyone. I think Ali's work has indicated that. It was interesting that, you know, you said 25% of staff on wards recognise there are 25% of patients who maybe should have had a DNA CPR policy document filled out for them. And when you looked at the PRFs, or the research at Lawson looked at the PRF forms from cardiac arrest, they recognised that 25% of the call-outs for the cardiac arrest team were on patients who retrospectively might have been better to have had a DNA CPR. So we've got a bit of work to do with that. But it's a whole new year, you know, we're going to practice more realistic medicine and hopefully get it right for most people. Because if that was my little 88-year-old granny or mum coming in, I wouldn't want her jumped up and down on her chest for those sort of things. And so it's to engage and try and have those decisions. You're right, Alan, it's a difficult decision. That's why seniors have to be involved.
I'm going to have to instigate the do not continue Barry Classen clause. because
Is
it's
that a
2
soapbox? So sorry.
It's 2 o'clock, and despite many other people wanting to ask questions, we've run out of time. So if you do have questions at the back you want to put specifically to the team, then do so. If you didn't, then sorry. Thank you very much to the team for coming. We'll see you again next week for something else. Virology next week. Virology. Oh, hang on. Do you want to say something else?
Yeah, just
Got awareness
sessions.
Hang on a minute, there's one final comment.
Just one final point. Can I just say that there are ongoing awareness sessions throughout Nine Wells and PRI over the next week that came out in the Vital Sign that was issued on the 23rd of December. So there's much more opportunities for